Hello, and welcome to our 5-minute medication review. Today we're going to be talking about atropine sulfate. Atropine sulfate does not have a trade name, and it's classified under three main categories. One, an anticholinergic agent. Two, an antimuscarinic. And three, a parasympatholytic. An anticholinergic agent means that they just work against the cholinergic receptors in the parasympathetic nervous system, otherwise known as our rest and digest side of the nervous system. Now, under those cholinergic receptors, there's two main types, which are nicotinic and muscarinic. Atropine works at blocking the muscarinic receptors, and also it works against or blocks and inhibits the parasympathetic nervous system. So, therefore, it is a parasympatholytic. Olytic referring to working against or opposing of. So, the way atropine is carried is 1 milligram in 10 mLs. Its pharmacology in actions is it blocks the action of acetylcholine as a competitive antagonist at muscarinic receptor sites in the smooth muscle. Um, so again, what that means is it basically, in essence, is blocking the parasympathetic nervous system. So it blocks receptors inside of your rest and digest nervous system. Remember, the two parts of your autonomic nervous system is the sympathetic nervous system and the parasympathetic nervous system. So you have your sympathetic side, which is your fight or flight, and your parasympathetic side, which is your rest and digest. Atropine works by basically blocking the parasympathetic side, allowing the fight or flight or your sympathetic tone to take over. Okay, so some of the things that we could see when this blocks or takes over is this: when we give somebody atropine, we would expect the heart rate to increase, the AV nodal conduction to increase. Okay, and it reverses bronchorrhea, so that's secretions in the airway, and bronchoconstriction. Okay, it reduces motility and tone of the GI tract. It reduces the action and tone of the urinary bladder, and sometimes can cause urinary retention. It dilates the pupils, and it will decrease sweat production. So all of these things we would see when giving atropine. The times we would use atropine in the field is for symptomatic bradycardia, and then nerve agent or organophosphate slash carbamate insecticide poisoning or toxicity. So, for symptomatic bradycardia, we would use this medication for people who are symptomatic, not asymptomatic, right? So, this is typically individuals who have a heart rate less than 60 and more severe, less than 40. Um, but we would give it for patients who are symptomatic, exhibiting one or some of these: altered mental status, chest pain, heart failure, seizures, syncope, maybe shock states, hypoxia, diaphoresis, to name a few. So, some absolute contraindications of this is like bradycardia without evidence of any type of cardiopulmonary compromise, and then an atropine allergy. Some precautions and side effects would be try to avoid it in hypothermic bradycardia. The key here would be to just kind of reverse the hypothermia. And then paradoxical bradycardia may result from doses less than zero point 0.5 milligrams. So atropine is just one of those drugs where if we give too little of it, it can actually have the opposite effect and cause bradycardia. So we really need to stick and adhere strictly to our protocols when giving atropine to a patient. So the way we can give it is IV, IM, or IO, and the dose is in the guidelines that attach to atropine administration are a bradycardia um, patients, and that is 1 milligram IVIO every 3 to 5 minutes. The max total is 3 milligrams. And then for our organophosphate or nerve agent poisonings, and that dose is 2 milligrams IVIO, and you can repeat it 2 times as needed every 3 to 5 minutes, okay, until the breathing or the shortness of breath resolves. So I hope you learned a little bit about atropine today. There's a lot more to talk about with atropine, but thank you for listening. I hope you learned something.